Welcome to LECOM Health Matters today. Our guest is our good friend, Dr. Joshua Tuck. Josh, welcome. Welcome
Thank
back. Josh is the chairman of the Department of Surgery and an orthopedic surgeon in our athletic department, and we welcome you to LECOM Health Matters. Thanks for being with us, Josh.
Thank you for having me.
ACL injuries. How many people get them?
Approximately 400,000 people a year suffer an ACL tear, and approximately 200,000 of those will undergo an ACL reconstruction.
And that's a difficult surgery, isn't it? The old traditional way before we get to the new way.
It is. What it requires is using tissue, either from the patient, which is autologous tissue, somewhere from the patient's body, that's then taken to the back table and turned into an ACL, or using tissue from a donor, cadaveric tissue, that's taken from the freezer, prepared, and brought to the patient for the ACL reconstruction.
In the traditional way, is it a longer recovery and a longer hospital stay?
Not necessarily. The recovery between the traditional way and the newer method is about the same.
Mm-hmm.
The benefit is the decreased comorbidity. And what we mean by that is the patient is no longer required to donate, if you will, their own tissue for a reconstruction or receive donated tissue for their reconstruction. We now have the ability to repair their native tissue.
Now, this new procedure, I understand, is called BEAR, which is Bridge Enhanced ACL Restoration. We're going to call it BEAR.
Yes, sir.
It makes it a lot easier, which I think, from what I've read about it, is really a novel and a new treatment. And I know you've done a few already.
I have. We did our first one here about 2 weeks ago, and it was the first one done in Erie, Pennsylvania. So it is a very new procedure.
Can you tell us a little bit about what it is?
Sure. So the BEAR, the Bridge Enhanced ACL Repair, is using a specialized implant, which is a collagen-based implant. And what we do is—
It comes from a cow, right?
Correct. It's bovine derived. And what it does is it allows for the patient's own blood to be absorbed and concentrated in a single area. And that implant is placed at the site of the defect on the ACL. And the bridge enhancement effect is that it allows the cells that would normally try to repair a ligament tear, in your body. Those cells are in place to do that job for you. The problem currently is when you tear your ACL, the environment of the ACL within the knee joint is not conducive for healing on its own. So there is a fluid called synovial fluid, which is the normal lubricant of your knee joint. That fluid, although it's wonderful for what it's meant to do, it does not allow the reparative cells that would normally do their job elsewhere in your body to do their job in the knee. And so the ACL does not have the capacity to heal itself. The BEAR procedure, the Bridge Enhanced ACL Repair, in using this implant soaked with the patient's own blood, it allows for a concentrate of the blood to stay in the area where it needs to be to enhance healing of the ACL.
How do you get it in?
You make an incision.
When you do a traditional ACL,
Right.
You're really opening up the entire knee.
We are. Where for the tissue harvest, a fairly large incision needs to be made to remove the tissue. Whether you're taking that from the hamstrings or the quadriceps or the patella tendon, you do have to make an incision. The incision for the BEAR implant is smaller, but still larger than a traditional arthroscopic incision. With that said, there's still usually only 2 incisions required.
And it's done arthroscopically.
Arthroscopic assisted, correct. So you start with an arthroscopic approach, identify and confirm that the ACL is torn, and then there is a series of parameters that have to be met to determine if the patient's a candidate for BEAR.
So it's not every patient.
Correct. It's
What
not
would
every
some of those
patient.
conditions be?
This procedure is best for patients who are younger, patients who are non-smokers, patients that don't have a lot of other significant ligamentous injury about the knee, patients without significant arthritis in the knee. Ideally, we get to the injury within 45 days. That's the best chance for healing with the BEAR implant. Also, ultra-elite athletes. Currently, the research isn't there to determine whether ultra-elite athletes will do as well. So for ultra-elite athletes, professional athletes, the reconstruction is still, at this point, considered the gold standard. However, the research and the numbers and the data continue to grow on the BEAR implant. And there's been over 2,000 of these performed now. So as the research and data starts to come back on this procedure, we're seeing that the results are similar, if not better than the ACL reconstruction.
So really, this is really new.
It's very cutting edge, bleeding edge.
Bleeding edge.
Yes, sir.
Is it in and out, or do I have to stay in the hospital with the BEAR?
No, in fact, the procedure takes less time surgically than a traditional ACL reconstruction.
Which would be how long, give or take? Depending on what you
A
find,
typical
obviously.
ACL reconstruction takes anywhere from 45 minutes to an hour. This procedure can take 20 minutes, half an hour, but it is same-day surgery. The patient comes in and goes home the same day.
And after the post-surgical rehab is pretty much the same as with the ACL.
It is. So traditional ACL is anywhere from 6 to 12 months rehab, depending on the protocol. This protocol tends to be closer to 8 to 12 months. Around 8 to 9 months is the average for most people. So the protocol and the rehab and return to play are similar between the two interventions. The difference, again, being that the BEAR implant allows the patient to maintain their own tissue, rather to heal their own tissue. So they don't have to go through what we call the comorbidity of taking tissue from elsewhere in the body. That's another site that the patient has to heal, has to recover from. And the BEAR eliminates that need.
Yeah, I think just so people understand, in the traditional ACL, it's at least two. When you harvest the tissue from their body, if you're going to take it from there, or a cadaver, if you're going to take it from the patient, that's a tear that has to heal, plus the actual ACL.
Correct.
The BEAR is far easier, it seems like.
It is.
You know, I have to ask this question because I think when people listen to this and when they hear this, everybody wants to be their own doctor.
Sure.
You don't come in and say, I want the BEAR, do you? This is a surgeon's, this is your determination based on what you see.
Correct. You have to meet, like I said, a series of pretty strict criteria. Now, with any new medical procedure, we anticipate that the indications will continue to expand as more data comes in. But initially, currently, as I've stated, it's best for that younger patient, newer injury, maybe not the elite athlete, but certainly an athlete can be well served by this.
When you say younger patient, Josh, I know it's 14 is the minimum. What's
Right. So people under the age of 45 are best served by this, but that is not a hard and fast rule. And there have been patients that have been done in their 60s with good results. And there have been patients that have been done much younger than 14 with good results. But traditionally, around the age of 14 to 40, 45 is probably best served with a BEAR.
And where did you learn this?
I actually learned it from a colleague, another sports surgeon, a friend of mine who practices in New Jersey, who learned it from friends of his who practice in Boston. So this actually started in the New England area in the children's hospitals and spread from there.
And we're one of the few around here that are doing it, from what I
We're
understand.
the only in Erie, Pennsylvania that's doing it.
So we're the only
Yes, sir.
ACL place
Repair.
that's doing it.
Yes, sir. We are the only, Mill Creek Community Hospital is the only hospital in Erie, Pennsylvania that's doing the BEAR.
Which really puts us on the cutting edge.
It does.
And when I listen to you, when you think of the advantages of it, if the patient qualifies for it, it seems to be a tremendous incentive to get it done if you got to get it done.
Right. So it's such a huge benefit. The exciting thing from the surgeon's perspective, again, is that we're able to keep your own tissue and heal your own tissue. And so if we can get to a point where the majority of procedures are BEAR, then maybe the day of having to spend time harvesting tissue and causing damage, if you will, elsewhere to your body will be a thing of the past.
Well, causing the damage when you harvest the tissue.
Correct.
Clearly, if you can eliminate that from the equation, because there are, I'm sure, infection problems and things that can happen.
There are.
You just eliminate an old variable.
100%. You know, when you harvest tissue, every time you take tissue from elsewhere in the body, you're having to give something up. It's a sacrifice. You're sort of robbing Peter to pay Paul, if you will. And so if I have to take a quadriceps tendon, for example, a portion of your quadriceps tendon from your body, those make excellent ACL reconstructions. However, there's associated quadriceps weakness after. If I have to take your patella tendon, there's an associated risk of ongoing knee pain after. If I take your hamstrings, there's a decreased push-off strength after. So everything comes at a cost when we take tissue from the body and use it for a different purpose. But that's not the case with the BEAR.
It really does sound like it's a tremendous achievement. And the fact that we're the only ones doing it in the area is really a first to you. Congratulations to do that. But I also think in terms of people who hear this, a real advantage for them to give you a call. Because if they qualify for it, they're going to spend not perhaps less downtime,
Right.
but they're surely going to spend less time in the hospital. It's going to be
Right.
less invasive, and their probability of healing is probably going to be much substantial.
Yes, sir. Absolutely.
If I could just switch gears for a second, Josh, when we talk about ACL, how do people protect their ACL? You hear this ACL injuries repeatedly.
Right. So the jury's still out on that. There's been a lot of research on various types of prophylactic bracing, which has not been found to be of any benefit. There are certain programs, certain rehab or prehab programs in place to help decrease the risk of ACL injury. But in terms of true preventive measures, we haven't quite cracked the nut on how to 100% prevent ACL tears.
We still don't know.
We still don't know. We know that there are certain training techniques and strengthening programs that can help decrease the risk. But in terms of eliminating the risk entirely, we're not there.
What's the most procedure you do in your practice these days?
I do a fair amount of ACL reconstruction, meniscus repair, and a lot of shoulder surgery, rotator cuff repair, labral repair.
And you do hands too as well? People who have hand issues?
Yeah, we have. Yeah, so a little bit. Sports surgery requires the ability to do a little bit of everything. Because athletic injuries are far and wide.
They are. They are far and wide, and they're frequent.
And they're frequent.
and they're frequent. And they require almost immediate care too, don't they?
They do.
Especially with the kids who are playing or the young people who are playing sports. It's not that they can sit back and let these things fallow. They've got to act on them.
You're 100% right. Yeah. Regardless of what injury we're talking about, the majority of the time, getting to it sooner is better than later.
And if people want to get a hold of us, I think this is still a myth. How do they do that?
Give us a call. It's easy. 868-7840. Give us a call. When you let us know that you've sustained an injury as an athlete, we do our best to get you in right away. For these very reasons, we know there's a timeline, not just with ACL repair, but with a variety of the injuries that we serve. Time is of the essence.
Yeah, and I think that's a point well made, Dr. Tuck, that when people call for that appointment, to share the specifics, if someone just had an injury playing football, basketball, baseball, and let the person know, I just got injured and I'm in pain, they get in a lot quicker if it's just somebody calling up for an ABC. If somebody's presenting with an injury, they need attention and they need it quickly.
Yes. Yeah, that's the importance of asking the right questions when a patient calls and communicating appropriately in the office, but that's correct. Yeah, time is of the essence with many of these injuries.
And just to recap, if I want the BEAR procedure, I got to come to you to get it. And I shouldn't say, give me the BEAR first.
Yeah, no.
But I could bring it up.
Absolutely, yeah. I think that hearing about it is half the battle. And I think patients at least being aware that there's something else out there that may not be offered to them just anywhere. Mm-hmm. I think that the American patient in this day and age is well informed.
Yes, they are.
And I think that they need to be an active participant in their care.
Just to clear something up, Josh, when the BEAR implant is planned, is it your surgical decision when you get there to do it? Because when you get in, you may see something that you may have to change course.
That's a good point. I have that conversation with patients preoperatively, and so we usually consent them for both. We usually consent them for a BEAR procedure versus traditional ACL reconstruction. In the event that we get in, for example, the tissue, the anterior cruciate ligament tissue, the stump that remains on the leg bone, on the tibia, has to be of the right length.
I noticed that when I was doing some research for this.
Right.
They called it a stump. It had to be a certain length so you could attach the sutures to it.
That's correct. And the suture has to be able to hold. And so after we pass the sutures, if we pull the sutures and they pull through the tissue's not conducive for repair. So again, there's a series of criteria, not only preoperatively, but intraoperatively, decisions we're making to ensure that you're a good candidate for the procedure.
And I think it's important that people understand that, as you would explain that to them anyways, but when you get inside and you may see something that prevents us, you may have to go the more traditional route. Correct. As opposed to the BEAR implant. But the BEAR implant really sounds like it's a tremendous leap forward in ACL repair. And you're the only one in town that's doing it. So we want to advise our audience, if they're interested, please give us a call. We'll evaluate you and get you in and do the best we can.
Yes, sir. Absolutely.
Dr. Tuck, chairman of the Department of Surgery at Mill Creek and our orthopedic athletic surgeon, I thank you for your time. Most especially, I thank you for being on the cutting edge of this. We're here to serve patients as best as we can and bring them the best care that we can. And this is a perfect example of us bringing a different, new wonderful care if you have to get an ACL repair done. And we thank you for bringing it to us, and thank you very much for your time.
Thank you.
This is Monsignor Rubino for LECOM Health.